Bismillahirrahmanirrahim. It will be the last session of our ropes, inshallah. So let's get straight into it. Gestational diabetes. Gestational diabetes mellitus, the pathophysiology is human placental lactogen secretion. Screening 24 to 28 weeks of gestation, 1 hour 50 gram glucose challenge test, and 3 hours 100 gram glucose tolerance test. The target blood glucose goals are fasting less than 95 milligram per deciliter, 1 hour postprandial less than 140 milligram per deciliter, and 2 hour postprandial less than 120 milligram per deciliter. Management is first line by dietary modifications and second line with insulin, glyburide, and metformin. Postpartum management is with fasting glucose at 24 to 72 hours, 2 hours 75 gram glucose tolerance test in 6 to 12 weeks visit. New onset diabetes after 20 weeks of gestation, increased human placental lactogen and placental somatomamotrophin in third trimester, pancreatic beta cell hyperplasia, and increased insulin resistance that will lead to gestational diabetes. The patients are universally screened for gestational diabetes mellitus at 24 to 28 weeks of gestation. Diagnosis: 1 hour glucose tolerance test or glucose challenge test if positive, 2-3 hour glucose tolerance test. Management: dietary modifications, 3 meals and 2 to 4 snacks with evenly distributed carbohydrates, proteins, and fats. Insulin as second line. Follow-up: postpartum screening is carried out because the patients are at risk of developing the type 2 diabetes mellitus. If screening is negative, repeat screening and should occur at 3 years interval. 3 hours 100 gram glucose tolerance test for screening in pregnancy. So fasting. It is Carpenter's, Kustan, and this is National Diabetes Data Group. So fasting must be more than 95 milligram per deciliter, 5.3 millimoles. 1 hour 180 milligram per deciliter. 2 hours 155 gram per deciliter, and 3 hours more than 140 gram per deciliter. If it is more than that, then it is a diagnosis of gestational diabetes mellitus. And for the national data group, fasting 105 milligram per deciliter, 1 hour 190, 2 hours 165, and 3 hours 145. 3 hour 100 gram oral glucose tolerance test for screening in pregnancy. A diagnosis of gestational diabetes mellitus is made when 2 or more of the plasma glucose levels are met or exceeded. Two-step approach for screening and diagnosing gestational diabetes mellitus. 24 to 28 weeks of gestation. Step 1 is administer 50 gram oral glucose load and check for the serum glucose 1 hour later. If the blood glucose is less than 140 milligram per deciliter, gestational diabetes is unlikely and no further testing is done. If the blood glucose is more than 140 milligram per deciliter, go for step 2. Administer 100 gram oral glucose load. Check fasting serum glucose each hour afterwards for 3 hours. Diagnosis of gestational diabetes mellitus more than 2 abnormal values. Look for blood glucose level. Fasting. Fasting must be, to make a diagnosis of gestational diabetes mellitus, there must be 2 abnormal values. If it is more than 95 milligram per deciliter, and according to the national database guideline something, it must be 105. We will talk about this table right over here. National diabetes data group. Okay, so 1 hour more than 180 or more than 190, more than 155 or more than 165, more than 140 or 145, depends on which classification they're asking you for. So to remember these national diabetes data group, add 10 to everything, right? Like these. What are they talking about? 105 and 190. How have they added 10 to this? Okay, like this. Okay. From 95 to 105, 10 is added. 180, 190, 155 to 165, and 140 to 145. Okay, we got it. Then we have the next thing over here, that is metabolic effects of human placental lactogen. So maternal metabolism and fetal metabolism. Increased human placental lactogen leads to increased insulin secretion and increased insulin resistance. Okay. Actually, it is increasing the insulin resistance, but to cope this, insulin secretion is also increased. Got it? Now, increased insulin resistance leads to increased lipolysis, increased proteolysis, and increased blood glucose. Increased proteolysis and increased blood glucose will lead to increased glycogen and protein synthesis, and increased lipolysis will lead to maternal energy source. Okay, then we have shoulder dystocia. Shoulder dystocia by definition is a failure of usual obstetric maneuver to deliver the fetal shoulders. Where, okay, it's not shoulder dystocia. Failure obstetric maneuver to deliver the fetal shoulders. Risk factors are fetal macrosomia, maternal obesity, excessive pregnancy weight gain, gestational diabetes, and post-term pregnancy. Warning signs are protracted labor, retraction of fetal head into perineum after the delivery, which is turtle sign. And wait for 3 to 9 months, it usually goes away. If not surgical correction, they are talking about herb Duchenne palsy, which can occur in the people who have shoulder dystocia and the children who have shoulder dystocia. Infant risks are brachial plexus injury, clavicular or humeral fractures, and hypoxic encephalopathy. Maternal risks are fourth degree, for example, rectal mucosa or perineal lacerations, and postpartum hemorrhage. Shoulder dystocia is caused by impaction of anterior shoulder behind the pubic symphysis. Then we have complications of shoulder dystocia, fractured clavicle, the clavicular crepitus bony irregularity, decreased Moro reflex due to pain on the affected site, and intact biceps and grasp reflex. Fractured humerus, upper arm crepitus and bony irregularities, decreased Moro reflex due to pain on the affected side, and intact biceps and grasp reflex. Herb Duchenne palsy because of C5 to C7 damage, nerve root damage, decreased Moro and bicep reflexes on the affected side. There will be greater step, extended elbow, pronated forearm, and flexed wrist and fingers, intact grasp reflex. Then we have Klumpke's palsy. Klumpke is horny because this causes Horner syndrome. There is a C8 to T1 involvement. So there will be claw hand. In the herb Duchenne palsy, we had a beta stiff hand. Here we have a claw hand in which we have an extended wrist, hyperextended metacarpophalangeal joints, okay, and flexed interphalangeal joints and absent grasp reflex. Horner syndrome of ptosis and meiosis and intact Moro and bicep reflex will be present. Sympathetic fibers run along CA to D1, so Horner's syndrome is affecting this patient. Wait for 3 to 9 months. It usually goes away. If not, do the surgical correction. Okay, so they were talking about Klumpke's palsy. Perinatal asphyxia, variable presentation depending on the duration of hypoxia, altered mental status, for example, irritability and lethargy, respiratory or feeding difficulties, and poor tone seizures. Okay, so bicep reflex is elicited by putting a thumb on the bicep tendon and then striking it with a hammer. So this is grasp reflex. When you bring something close to the palm of the child, of the infant, the child tends to grasp it, and this is the Moro reflex, which is the child calls for life or something. Okay, then we have management of shoulder dystocia, that is be calm. So management of shoulder dystocia is be calm, that is breathe, do not push, elevate the legs and flex the hips, thighs against the abdomen, which is Mac-Robertson position, call for help, apply the suprapubic pressure, enlarge the vaginal opening with episiotomy, and M is for the maneuvers, that is deliver posterior arm, rotate the posterior shoulder, which is wood screw, apply pressure to the anterior aspect of the posterior shoulder, okay, adduct posterior fetal shoulder, that is Rubin procedure, apply pressure to the posterior aspect of the posterior shoulder, mother on hands and knees, all fours, that is Gaskin procedure, and replace fetal head into the pelvis for cesarean delivery. So place the head back and do the Zavanelli procedure. Okay. Then we have the next thing, that is herbs. Okay, so it is herb Duchenne palsy, herb Duchenne and Klumpke's palsy. So Klumpke and herb Duchenne palsy, there is a difference between them. Here we have, you can see that this is a claw hand and this is beta stiff. So in Klumpke's paralysis or palsy, metacarpophalangeal joints are hyperextended, the wrist is extended, and interphalangeal joints are flexed, and the forearm is supinated, and the other arm is normal. This is Klumpke's palsy or claw hand. On the other hand, the beta stiff hand, we have the wrist and fingers are flexed, forearm is pronated, elbow is extended, and upper arm is adducted and internally rotated, and the other one is the normal arm. Okay. Then stress urinary incontinence, most common cause of involuntary urine leakage in the pregnant women. It occurs with increased intra-abdominal pressure, standing from sitting position, coughing, laughing, stress urinary incontinence. It can happen in the pregnant women. Stress means pressure, so it is happening because of increased intra-abdominal pressure. It should be differentiated from the rupture of membranes because urine can enter the posterior vagina. What? It should be differentiated from the rupture of membranes because urine can enter the posterior vagina. Okay. In stress incontinence, urine somehow can enter the posterior vagina and it will look as if it is rupture of membranes when actually it is urine. Nitrogen positive test is done. If it is nitrogen positive and burning on microscopy is taking place, that is confirmative for amniotic fluid. Okay, so posterior vagina through retrograde vaginal voiding due to effect of growing uterus and posterior changes while voiding. So the differentiating points are no burning on microscopy. Okay, so while voiding, the urine can go into the vagina and then they can come out of vagina. Okay, so no burning on microscopy, no increase in fluid in vagina or on valsalva. Nitrogen testing is negative. Stress urinary incontinence is common following labor and delivery due to following mechanism. That is weakening of the pelvic floor muscles, stretch injury to the pudendal nerve, which helps maintaining the continence by innervating contraction of the external urethral sphincter. Pudendal nerve is also the main sensory nerve of the pelvis and damage to it can result in decreased voiding sensation. Management of postpartum stress or urinary incontinence, observation and reassurance till less than 6 weeks postpartum. Patients with chronic stress urinary incontinence, give them the continence pessary and mid-urethral sling procedure. Stress urinary incontinence, physiology, urethral hypermobility and intrinsic sphincter deficiency. Symptoms include leakage with the Valsalva maneuver, for example, coughing, sneezing, and laughing, and intercourse. Risk factors are pregnancy, especially vaginal delivery, obesity, and chronic high impact exercise. Treatment is pelvic floor muscle or Kegel exercises, lifestyle modification like weight loss, continence pessary, and mid urethral sling procedure. Causes of hyperandrogenism in pregnancy. So these are placental aromatase deficiency, no ovarian mass, high maternal and fetal virilization risk, resolution of maternal symptoms after delivery. Leutoma. It is the, I think it is the tumor of the corpus luteum, solid unilateral bilateral ovarian masses, moderate maternal virilization risk, high fetal virilization risk, spontaneous regression of masses after delivery. Theca lutein cyst is cystic bilateral ovarian masses, moderate maternal virilization risk, no fetal virilization risk, spontaneous regression of masses after delivery. Then certainly Leydig cell tumor, solid unilateral ovarian mass, high maternal and fetal virilization risk and surgery required second trimester or postpartum. Then what is malignant hyperthermia? It can be a complication of an anesthetic and it can happen otherwise as well. Malignant hyperthermia epidemiology, genetic mutation alters the control of intracellular calcium. It is triggered by volatile anesthetic, succinylcholine and excessive heat, but the underlying problem is genetic, which means that genetic mutation alters the control of intracellular calcium. Manifestations: masseter muscle generalized rigidity, sinus tachycardia, hypercarbia resistant to increased minute ventilation, rhabdomyolysis, hyperkalemia, and hyperthermia, that is a late manifestation. Treatment is respiratory and ventilatory support, immediate cessation of the causative anesthetic, and dantrolene, that is ranolene calcium channel blocker. Then we have cesarean incision types. There are two types of incisions. They can be what? Skin incision and uterine incision. Actually, there was phalansteal incision and there was like this incision. I don't remember the name of that. I think it was the protomy incision or something. So classical vertical incision is higher risk of uterine rupture. So this is higher or classical or vertical incision. Then low transverse incision, which is given over here. Okay, in classical incision, we give two incisions. The first one is over here, vertical uterine incision, and there we give skin incision for some reason. Okay, so then we have low transfer in cesarean. There is a low risk of labor after cesarean. So like, what is the meaning of that? I don't know. So this is the side of cesarean, and there is a low risk of trial of labor after cessation. Trial of labor after cessation. Okay. So trial of vaginal birth after uterine surgery. Uterine surgical history of vaginal birth surgery. Low transverse cesarean delivery with a horizontal incision. There is no trial of labor. Trial of labor is not contraindicated. What is trial of labor? Let me see that.